We're so thrilled to have all of you here. Looking back on the past 2 days, I think we really made the most of our short time together count between our social outings and all of our clinic visits. We've accomplished a lot, and I think we should all be proud of our contributions to the success of this clinic, you as the patients. We each sacrificed a lot to be here. The travel with our DESSH loved ones is not easy. The time away from work, the time away from our other family members at home, and the expenses we incurred are not little sacrifices, so I want to give all of us a round of applause. Of course, we have a lot of other people to thank for this conference. So we had a ton of sponsors, and I'm going to go through them, and I want you to bear with me because I think it's important that we list everybody. So first and foremost, thank you to Washington University and St. Louis Children's Hospital. I want you to know that WashU is a recognized center of excellence for rare disease by the National Organization of Rare Disorders. So we are very fortunate to call this place the home of the DESSH Clinic. Of course, thank you to the medical team at WashU, including Dr. Patty Dixon, she's director, and Dr. Marwan Shinawi, professor of pediatrics for the Division of Genetics and Genomic Medicine. I also want to thank the doctors who volunteered their time to see us at the clinic. This is not an exhaustive list, but Dr. Shinawi, Dr. Weisenberg, Dr. Reynolds, Dr. Mayerson, Kathy Sisko, RN, and all the clinic staff who assisted us in the PCRU. Thank you to all the clinic coordinators at St. Louis Children's Hospital who planned this many, many months in advance. Dana Kiley, Yolanda Phillips, and Kathy Sisko again. And finally, I want to thank everyone that donated or provided some sort of discount for our events while we were here. That includes, these are all St. Louis businesses: Sugar Fire Barbecue, The Shack, Kendra Scott, Whole Foods Market, Chick-fil-A, Ted Drew's, City Museum, and Colleen's Cookies. And I also want to make a huge thank you to Emily Smith and to Susan Ford for all of the coordinating and organizing that they did to make this happen. It's been, I think folks who were here last year noticed a difference between last year and this year's conference in terms of the hospitality we received in St. Louis. DESSH community members Stephanie Salam and Melissa Sidebottom, you guys helped out with some preclinic stuff, and that was really appreciated. And of course, thank you especially to Colleen Tosti for her months of planning and preparation with me leading up to this event. And a special thanks to my husband, Joseph, for his support. There's a lot of late nights, and he held it all together for us. And last but not least, I want to recognize our DESSH Board of Directors for their commitment to our mission and to support the patients and families and advance the research for DESSH. Many of them are here today, and I don't know if everyone knows who's on the board, so I want to mention everyone by name. We have Joseph Piccirillo, Patty Cardona, Colleen Tosti, Nasheen Wasim, Amy Mitchell, Melissa Sidebottom, Carter Smith, and Susan Ford. And those who couldn't be here in person, Amanda Murphy, Tara Moore, and our UK liaison, Claire Studley. Thank you guys for your service. Okay, a few items before we get to the good stuff. We're on a tight schedule today, so the format of our agenda in most cases will be a presentation followed by audience Q&A. I'm going to be watching the clock. We collected your questions in advance, and we shared them with the presenters to factor into their presentations. I'll also be asking additional questions that were sent in advance from our virtual community who is joining us via Zoom right now. There will be a break around 10:30. Feel free to check in on your child at this time if they're upstairs. I want to let everybody know the presentations will be posted online at deshclinic.com early next week. So we don't have printed here, but you'll be able to access them shortly. And then a recording of this conference is also happening, not via Zoom, but via our videographer back there, and that'll be made available once it's made available to me. So I ask for a little bit of patience on that. All right, now we're really on to the good stuff. So I'd like to begin with our first presentation with the man who needs no introduction, the big honcho here at WashU for our community, Dr. Marwan Shinawi.
Thank you, Caitlin. Okay. Thank you, Caitlin. And I really appreciate this introduction. And actually, I have a slide for acknowledgements and things like that. I'll leave this to the end. Just because of time limitation, I would start with the presentation. So the main aim of this presentation actually to go over the clinical findings of related to DESSH syndrome. Most of the information I already shared with you, although actually I have additional data from the clinic from last year. Okay, so we'll talk about the name of this condition, whether this is going to change in the future or not, who decides the name of genetic syndromes, and things like that. All right. So DeSanto-Shinawi actually was first described in 2015. At that time, we described the condition in 6 patients that have been seen either here or in other institutions. The whole story actually started with 2 siblings that initially seen in 2014. They came to me with ADHD, evaluation of ADHD, intellectual disability, and some facial differences. My thought initially that they inherited the condition maybe from their parents. The assumption initially that this was actually what we call an autosomal recessive condition where parents are carriers and they pass actually the mutation to their kids. But I was surprised at the time with the results that I received with the exome sequencing. So fortunately at the time in 2012, 2013, we started doing the exome sequencing and we received these results of a candidate gene in the WAC gene. I knew nothing about this gene, and I started actually communicating with other physicians, other researchers, and through a system that we call Gene Matcher, I was connected with other physicians who actually have patients with mutation in the same gene. And this is the story started there. They started sharing with me clinical findings, pictures, and immediately I recognized the similarity between these patients. And we started collecting data about neurological findings and behavioral difficulties, and the pattern came to what later became known as the DESSH syndrome. So many clinical findings are obviously delayed milestones, later in life intellectual disability, decreased muscle tone, and other neurological findings, behavioral difficulties. I'll elaborate on these things, so no worries, this is just the introduction. GI abnormalities related to constipation, acid reflux, and eye abnormalities as well as facial differences. And this data actually from last year, I collected this data from last year. You can see actually the frequency of the clinical findings. I don't see very clearly there, but I'm sure that delayed milestones, gross motor delay, fine motor delay was found in 100% of patients. Speech delay 100%, and facial differences also very common. Found almost in every child. And we'll talk about this, what is the significance, if any, for these things. Behavioral abnormalities actually are found in more than 90%, followed by hypotonia, sleep abnormalities, and gastrointestinal problems in about 77%. Ophthalmological findings in about 2/3 of the patients, brain MRI abnormalities 53%, and seizures 47%. You would ask, the seizures, initially I didn't recognize this as a part of the genetic syndrome, but over time I started realizing that more and more kids exhibit some kind of seizure. Fortunately, these are milder seizures that can be controlled with a single medication, and in many cases it would resolve over time. I think it's a kind of bias here in the cohort that we had last year. This can be a kind of selection bias because those who are mostly affected, they wanted really to see us in the clinic to get a little bit more evaluation. With the larger set of data that I have, which is about 95 patients, the frequency of seizures way lower. It's somewhere between 20 to 22%. So how common actually DESSH syndrome? It's unknown at this time, but as you noticed, it's considered as an ultra-rare condition. The definition of ultra-rare, this is really below 200,000. Any condition below 200,000 worldwide, it's considered ultra-rare. So under this definition, obviously, almost every genetic condition would fit. But I was surprised, to go from 6 patients to quickly go to, my estimation now, at least there are around 200 patients that either documented or through my communication through emails with other providers, with other professionals. This is my estimation. 42 of those cases are well documented in the literature. As I mentioned to you, we are analyzing the data now of about somewhere between 92 to 95 patients, which is a large cohort. I'm going to share some of the data that we already collected. But we anticipate actually more and more cases to be discovered. I mentioned to many of you, this is a good thing. I see this as a good a trend, because the more cases we diagnose, the higher the interest, and many researchers will become interested in this condition. Even if we think about interventions, it's way easier to convince pharmaceutical companies to invest in a condition which is not really extremely rare. If you have hundreds of patients, then you definitely have the case to present for them that we want really to pursue some kind of intervention. And this is regarding the diagnostic, how we make a diagnosis. So usually the diagnosis is made with, it's difficult to make a clinical diagnosis, and definitely except for those who are heavily involved in and they have seen many patients with DESSH syndrome, it's difficult for them just based on facial differences and the pattern of the clinical findings to make a clinical diagnosis. And the most common scenario to make this diagnosis now, this is what we call with the exome or whole genome sequencing. And the data from last year, 13 out of the 15 patients, actually this way was the diagnosis made. But more and more insurance, if insurance is not really approving this kind of testing because of cost and the other considerations, we have different panels. Unfortunately, the WACGN was included in many of these panels of intellectual disability, seizures, more recently autism. So all of these definitely will increase the yield. One patient was diagnosed with a chromosomal microarray. This is to detect microdeletion, and I have a slide actually about that. But these are the minority of patients. So what is the clinical course? You would ask how we can make this diagnosis. So many of you most likely remember when your child was born with this condition, nothing was really unusual when they are born. Pregnancy went well, delivery without any complication, and this is also based on the data we have. Birth weight, birth length, everything really was completely fine. until you get to the point of expectation of acquiring more milestones, either sitting and things like that. So this is about the time we start noticing some unusual things. And it's rare actually to make a diagnosis below the age of 1 year, because usually you go to the primary care physician, to the pediatrician, let's wait a little bit, maybe this is just a normal pattern with a slight delay in milestones, which I understand definitely, but this is the usual pattern, delayed milestones, but also there can be some hints there. For instance, acid reflux and feeding difficulties can be initial signs during the first few months of life or a few weeks of life. And then constipation can be actually an early presentation. Later on, maybe they will be seen by an ophthalmologist for strabismus or crossing eyes, abnormal eye movements. We did notice that many patients exhibit stuffy nose and runny nose more often than kids without this condition due to recurrent respiratory infection, which is really a very important field maybe to research, to study in the future, the immune regulation. There are kids who are having immune deficiency, and there are a few kids receiving actually IVIG. This is kind of immunoglobulins that are deficient in their body and they need that. I'm aware also of few cases with short stature and due to growth hormone deficiency and also low blood sugar, which can be related directly to growth hormone deficiency, but we are trying also to investigate this issue, can be unrelated to that as well. When they get older, the picture would be more obvious. So parents would notice in more obvious way the delayed milestones, the gross motor delay, which is part of that is related to the decreased muscle tone. And usually the age of walking, somewhere between 20 to 30 months of age. Fine motor skills also are relatively common, although usually these are not really very essential in early 2 years. They became more obvious later on. Buttons, zippers, handwriting, shoelaces, and things like that. Language acquisition can be significantly delayed. There are usually the average to start saying single words around 20 months of age. Obviously, this is the average. There is a range. And the sentences, many kids actually need more time, 3 to 4 years of age. Potty training is usually delayed until maybe 4 years of age.